in terms of in terms of coverage decisions, patient-reported outcomes are just really beginning to come in. Say in some of the drug studies, FDA is beginning to use it in their approvals, and frankly, in oncology, the payers we follow FDA. If it's FDA approved, at least we will initially approve those things. So it is patient-reported outcomes are really coming into some of those specific coverage decisions. The other thing that we're beginning to incorporate various things on patient-reported outcomes are in accountable care relationships and value-based relationships, where we're beginning to look at those across a population of patients to try to determine, say, bonus payments to a system based on patient-reported outcomes is one of several factors in a payment system.
And those are collaborative programs,
right,
so that the providers in that environment are really being able to give the payer feedback that this is meaningful, this is not meaningful, this we can do, this we can't do.
Every one we do with them, we've come to mutual agreement with the provider before, and we work them independently with each of our systems as we do them, and really try to use, often provider systems are using their own patient-reported outcomes, their own patient satisfaction, or even functional status assessments in some areas, and we will take their data and report it back. So we really want to develop these in collaboration with the people taking care of the patients.
Yeah, I'm still struggling with, in my mind, there are some, kind of simple, keep patients out of an ER.
Yeah.
That's pretty straightforward to me.
But it's not patient-reported.
Well, but a patient would say, if I don't go to the ER, that must mean I'm doing better. I don't want to be in an ER.
That's an easy stuff for us to measure. We paid the check.
Exactly.
We know they were there.
I don't want to be in a hospital, and the fewer days I'm in the hospital, I'm happier.
Yeah.
I mean, it's like, again, we've got these things we could already be using or should be using.
We are.
And to some extent we are, but we're not calling them patient-reported outcome because somehow it's not a direct patient report, but it really is a great measure of quality of life.
Oh, it is.
Keeping patients at home, at work if they're working, out of an ER, out of a hospital, it speaks volumes.
Yeah, we're actually able to measure that now. We can measure admission rates, days in hospital, ER utilization. And this is just really just taking it a further step, just refining it. Those are really the key measures, and we usually use some of the old patient reporting. We're beginning to introduce those just as minor modifications, just to say there are some domains of quality that we may not be capturing as well from what we've done traditionally.
Mm-hmm. So I've been surprised in my experience with my patient population when I was treating patients a few years back, that they didn't embrace orals to the extent that I thought they might have. It's interesting, for so many different reasons you could make this list. They enjoyed coming to the office. The office was a support center for them. They had somehow greater confidence. If you inject it in my vein, it's going to do more than just a pill. Then there are the structural problems that I might have a bigger copay with a pill that I have with my injectable therapy in the office, depending on the design and the nature of the oral therapeutic. So it was interesting that there seems to be this almost intuitive reasoning that, of course, you'd rather take a pill. There's also the element that somehow pills are going to be safer and pills are going to have less side effects. That seems to be part of the mindset of most people. And yet the reality is, and certainly for the host of tyrosine kinase inhibitors, the first round of oral oncolytics, many of them were extremely toxic and more toxic than the intravenous drug treatment counterparts that were being used in the clinic. So there's a lot of education that has to happen around oral oncology, not just for patients, but I think for the broader stakeholder group to understand what its role will be in the long term. Clearly, if it's unique, if it's a precision therapy that is unique and effective, and it increases survival, it's going to win. But so many of them don't do that.
Yeah, I agree completely. We see that a lot in terms of courses of the oral oncolytics that are not tolerated by patients. They take a 5 days, and the course is finished. We see a lot of terminations of care. This is seen quite frequently, especially with some of the NIBs, and that there's the concept that these are more easily tolerated drugs just doesn't really hold that well across it, and the patient perception that it's stronger if it's IV. So I don't know how this plays into that. I think there are some issues with older patients, more debilitated patients. Just getting to the doctor is a problem. Mm-hmm. In the Medicare population, getting your daughter to drive you to the doctor, schlepping in and out of the car through the parking lot, and doing some of those things. I think those are some quality of life issues.
Although they need that physical activity. No.
They do, but they can do that. They may be able to do that more than in the parking garage of the local facility.
I agree.
And I think so. There are some issues in doing that, but I don't really see necessarily that that's a great quality of life improvement for a lot of patients. And then the question is the role, too, of agents like oral agents. Are there, even when cure is not going to be possible or even life extension, is there a role that they're actually palliative? Is there something about that drug that's reducing tumor burden, maybe reducing pain over time, and trying to assess those agents and using those agents and other agents? And, there's sort of some metrics about the quality of care around end-of-life care as did not receive chemo in the last 30 days of life. That's a COPE metric. Right. And maybe a round of chemo, if it actually was well tolerated and reduced tumor burden and pain for a few days, might have been something that could have been that might have been appropriate in that context.
Right.